Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School. Recently, we've posted a number of discussions as it relates to the gut biome and the influence on different disease axes, and in particular, growing interest as it relates to the gut-liver axis, where a lot has been written, and certainly there's some very recent provocative studies, particularly from China, that this group looked at the evaluation of multiple hepatic diseases and also looked at precipitous invocation of Tylenol toxicity, acetaminophen toxicity, or ischemia, hyperreperfusion, and showed that modulation of the gut microbiota were found to modulate the liver injury. And they turned now to portal hypertension. Now, why is that relevant to us in clinical medicine? I'll talk about this translational study because I think it's quite provocative. Portal hypertension is certainly the driving force that we see in complications, the major complications of cirrhosis relating to variceal bleeding and bacterial infection. So actually the leading cause of death in patients with cirrhosis. The pathobiology is actually due to not only the increased portal pressure, but that's because of the hypervascular effect of the hyperdynamic effect of the splanchnic the circular return to the liver, and this is coupled with an elevated intrahepatic vascular resistance. So the two go hand in hand to create portal hypertension. Now, the current pharmacotherapy that, unfortunately, at least in present, is directed at beta blockers, which lower the portal pressure by actually decreasing the portal flow, but not at all affecting this intrahepatic vascular resistance. So now the investigators, again from China, the same group, looked at the effect of a portal hypertensive model. They used carbon tetrachloride intraperitoneally in mice or a bile duct ligation model, developed portal hypertension, and they were focusing particularly on the activated stellate cells and modulating these. These are things that are induced by injury, and these are clearly executors of the elevated intrahepatic vascular resistance. They not only produce a large amount of collagen and fibrosis related as it results in the liver fibrosis, but they also enhance the cell contractions that relate to aggravation of the normal contraction of the intrahepatic vasculature, the microvasculature, so portal hypertension. What the investigators looked at particularly was that there was a way to inhibit this stellate cell activation, particularly by inhibiting glutaminase, which they found that glutaminolysis was a way that these bile duct, these activated hepatocellular cells were activated. And so they directed what would change that. And they found that there was a metabolic byproduct of urolithin A that changed inhibited these hepatocellular stellate cells and the collagen production. And they looked at an animal model, and they were actually able to find that there were certain, because it's a bacterial metabolite, there were certain bacteria that led to the production of this urolithin A. In that context, it was Lactobacillus murinus, which is not something that we have in commercially available form, at least from my review, from anything in the Lactobacillus products. But nonetheless, they found that this had a dramatic effect on the portal pressure and the fibrotic changes in the mouse model. They actually then looked at a cohort of their own patients with portal hypertension and sex-matched healthy controls and showed that the urolithin A levels in the feces and plasma with the portal hypertension were notably lower in the feces and plasma, and that they also correlate inversely with the degree of hepatic decompensation. So their cirrhosis, their Child-Pugh score, or encephalopathy scores, these are all changed as it relates to the correlation of low urolithin A. So how do you get urolithin A? Well, it's a metabolic byproduct, particular of something that's a natural food product. L-glutanins are something that we see in pomegranate juice, particularly in nuts. Almonds and walnuts are very rich in these. There are a variety of foods that produce this. So should we think about maybe increasing this in our population at risk in portal hypertension? We don't have any interventive studies in this, but let's take a look further. That first of all, of these patients that had urolithin A levels, and then they've looked at a number of different patient populations, only about 10 to 14% of people, normal people, healthy people, actually have urolithin A levels based on their exclusion of diet. And they looked at intervention trials giving them pomegranate juice or a supplement, and they found that they increased in the pomegranate juice they get up to 40%. So what does this mean? Well, in the translational message, should we rush out and try probiotics? No, I don't think that's the answer. We do have dietary supplements. Urolithin is available. It's been approved by the FDA as a food supplement from 2017. It's been given a GRAS, which is generally regarded as safe, certification in 2017. Primarily, it was used in skeletal and cognitive skeletal muscle increase and cognitive treatments, and there are a few RCTs on this in those areas. But now the question is, what does it do with portal hypertension? The answer is we just don't know. The animal translational message here is quite provocative. I see no interactions or downsides in safety, and I'm not advocating its use presently in clinical trials, but I want you to look at this because it's something that I think should be provocative for investigators in this area. Really getting the microbiome again to use it to our best effect, but maybe we take the microbiome when we can use it, or maybe we even jump past it to the metabolites and use the metabolites as the additive as it is with urolithin A. So lots of new answers, but translational message here as it relates to the gut microbiome and the gut-liver axis. I'm Dr. David Johnson. Please give it some thought. I found it quite provocative. Thanks for listening.